Hello, hello. So, welcome, clinical problem solvers, to another Rafael Medina subspecialty virtual morning report. My name is Hui Tin. I will be facilitating today's session and it will be focusing in neurology. So, today we have two amazing clinicians from Emory School of Medicine. So, as our case discussant, we have Dr. Helen Shi. She is a neurohospitalist and assistant professor at Emory School of Medicine. So, Dr. Shi, would you like to unmute yourself, say hello to everyone, and maybe tell us a little bit what do you enjoy to do outside of medicine?
Hi, everybody. Good evening from Atlanta. Good morning to some of you who it might be morning time. I'm Helen Shi, one of the inpatient neurologists at Emory University Hospital in Atlanta. Some things that I enjoy doing outside of medicine. I like hanging out with my three kids. They're 2 years old, 4 years old, and almost 9 years old. We like to go hiking, exploring Atlanta. We've been here for 5 years, but with the pandemic, it kind of feels like we've really been outdoors for the last 2 years. Um, yeah.
Oh, amazing. Thank you so much for sharing. So, and we have our case presenter for today. We have Dr. Zac Owens. He is a PGY 3 internal medicine resident, also at Emory School of Medicine. So, Dr. Zac, do you want to unmute yourself? And I'm going to ask you the same question. What do you like to do outside of medicine?
Yeah, hey everyone, I'm Zac Owens. I'm one of the third year medicine residents at Emory. I'm super excited to be here and to present this case to Dr. Shi. I'd say normally outside of medicine, I like to do anything outdoors, like hiking, running. I'm getting married next Friday, so lately all of my time has been spent with like the final touches of wedding planning.
Wow, oh my God, that is so exciting. Oh my God, it's gonna be great. It's gonna
Yeah.
be a lot of things going on, but I think you will be great today. So let's see. Today we have actually two of the CP Solar members who's gonna helping. Parisa is gonna be scribing, and we have Kusha. She's gonna do teaching point. And Parisa, whenever you're ready, you can share the whiteboard so we can start the case. Let's see. Great. Thank you so much, Parisa. So, Dr. Zac, you feel free to start with the first allogram.
All right, so we'll go ahead and get started. The chief complaint is found unresponsive. And I'll go ahead and dive into the HPI. So this is a 49-year-old female who is currently residing in a residential drug treatment program for cocaine use, who was brought in by EMS after being found unresponsive with dried blood at the left corner of her mouth. She had a pulse and was breathing spontaneously and was awake, but just not responding to or acknowledging commands. And then at baseline, she is functionally independent and has no issues with speech, communication, ambulation, or anything like that. Her last known normal was 11 p.m. the night before this admission, and her point of care glucose with EMS was 130. And we don't have any other information provided from EMS, family, or the facility she was at. All we can see is that she had been to the ED several times over the past few months for recurrent headaches, but there was no lab data or imaging available for those.
Oh, wow, Dr. Zac, that is a very rich first aliquot. So, Dr. Shi, my question to you is that the chief complaint is a very interesting one. So, as a neuro hospitalist, how would you approach this chief complaint of found unresponsive?
There's so much to talk about. So, with being found unresponsive, I mean, if I were to get this phone call, if I were holding the pager, typically our residents hold the pager, but if I were covering like during didactics and I get this page, um, or if a resident gets this page and then discusses the case with me urgently, I would want to know, are they still unresponsive? Do they still have neurological deficits right now? Because with hearing of a last known normal of 11 p.m. last night, the things I want to know are what time of day is it right now that we're getting this call? Are we within 24 hours of 11 p.m. when she was last known normal? Could there be something that vascular that has occurred, like an ischemic stroke or a hemorrhagic stroke, that would need to be addressed very urgently? So I would, if we are within 24 hours of her last known normal and she's still with neurological deficits right now, I would want a stroke alert to be activated for us to evaluate her urgently. It seems like she's in the emergency department, and in our emergency department at Emory, our protocol is that if somebody's within 24 hours of last known normal, the emergency department attending is supposed to assess the patient as well, and then activate a stroke alert if they still have neurological deficits and the last known normal is within 24 hours. With so I guess, could I ask that question? Are we within 24 hours of last known normal, and does she have neurological deficits currently?
Yeah, so we are within 24 hours. And why don't I go ahead and give you the physical exam so we can kind of play it true to how the case would pan out in real life. Does that sound good?
Great.
Okay. So I'll go ahead and start with her vitals. So her temperature was 99.7. Blood pressure was 193 systolic over 87 diastolic. Heart rate was 122, and her respiratory rate was 22, and her O2 sat was 99% on room air. So in general, she was uncomfortable appearing, agitated, trying to get out of bed despite being in 4-point restraints. On her HEENT exam, she had a left lateral tongue laceration, but no jaundice, palpable lymphadenopathy, or meningeal signs. Then from a cardiac exam, she was tachycardic but had normal rhythm, and there were no murmurs. For her lung exam, her lungs were clear bilaterally with normal workup breathing. Her abdominal exam, soft, non-tender, non-distended, and then her extremities and skin, warm, well perfused, and no rashes. And then going into her neurologic exam a little bit more, for her mental status, she was awake but disoriented, intermittently following simple commands, but was mumbling often incoherent speech and wasn't able to participate in any naming or repetition. Her mom was present during the exam, and when we asked her to identify her mother, the patient said, "She's not my daughter." Her cranial nerve exam was a little bit limited since she couldn't participate, but she did track the examiner across the room, and all other cranial nerves we could assess were normal. She didn't have any facial droop, no ptosis, no tongue deviation, or anything like that. From a motor exam standpoint, she was moving all of her extremities spontaneously and pulling very strongly at her restraints, but wouldn't follow commands well enough to fully assess, do like a normal neurologic motor exam. And then for coordination, gait, and reflexes, she didn't have any clonus, had a downgoing plantar reflex, and otherwise wouldn't participate enough with us to complete those components of the exam.
I'm sorry, I might have missed this. Did you say that she's moving all extremities symmetrically?
She is, yes.
Okay, great. And her reflexes were symmetric, and you said that their plantar reflexes were normal? Oh, you're muted, Zach.
We had a hard time assessing her reflexes with how much she was moving around. Yeah.
Amazing, amazing. So, Dr. Shi, this is a very intriguing physical exam. So, my question is, with this, there's a lot of pertinent positive with the chief complaint, HPI, and the physical exam, is there any differential diagnosis that is coming to your mind? If there is, can you tell us what are you thinking?
Yeah, absolutely. So when I walk into a room like this, I mean, so if we had gotten this as a page, we would say, okay, you should activate a stroke alert. This patient is not back to baseline and their last known normal is within 24 hours. We need to come evaluate this patient urgently. And walking into the room as we're getting the story from whether it's from EMS or the ED or um, another provider, the things that I'm listening for are what is the blood pressure? Is it something that we need to, is it something that gives us a clue for the etiology? And also, is it something that we need to manage urgently, such as in the case of if we're going to consider giving them TPA or TNK for in the case of an ischemic stroke? I think that all of us seeing that the blood pressure is elevated, and I saw that in the comments, people were saying it seems like this person's in sympathetic overdrive. Maybe this could be PRES, that's posterior reversible encephalopathy syndrome. Those are also things that I'm thinking of as well. For this case of a 49-year-old woman who's in a residential drug treatment program, it makes me wonder if she could be at risk of seizures or vascular issues that could also precipitate seizures. I think all of us are drawn to the fact that she was unresponsive and there's blood coming out of the left corner of her mouth and a left lateral tongue laceration. I think that all of us are thinking, could she have had a seizure with postictal confusion, as it seems like at the moment she's not actively having convulsive seizures, although we can't completely rule out the possibility of subclinical seizures, also called non-convulsive seizures. When people are seizing, it does cause a major sympathetic surge, and so people do become hypertensive, tachycardic, the respirations increase, they can be diaphoretic, and so it could be that she recently had a seizure, and so she still has that elevated heart rate and elevated blood pressure, or she could be having subclinical seizures right now that we could see on vital signs as having an abnormality. This is an aside, but one thing that I like to tell the residents is that when I was a resident, there was, and I was on night float, there was a patient that every night he had a glioblastoma, and unfortunately he was like trach pegged. The family still wanted to continue care, even though there were not great treatment options for him at the time. And he every night would get tachycardic, hypertensive. And as the overnight night float resident, I was, the first night I evaluated him for PEs, we did EKGs, we did, he couldn't talk to us, but we, did a full kind of, cardiopulmonary assessment. And we gave him fluids. We, there were a lot of thoughts of what it could be, but we didn't put him on EEG. And then it wasn't until the third night we put him on EEG, and he was in subclinical status the entire time. And it was really just manifested by his heart rate and blood pressure being elevated. Okay, that's an aside. But anyways, for this patient, I'm thinking about seizure, but then also if there could have been something vascular that precipitated the seizure, for example, an ischemic stroke or a hemorrhagic stroke. When we have when somebody has an ischemic stroke, our cerebral autoregulation also does cause us to become hypertensive. For example, a young person who does not have hypertension, if they have an ischemic stroke, for example, from some hypercoagulable condition or something else like infective endocarditis or something, they don't have hypertension at baseline, but they're having an ischemic stroke. They are going to be hypertensive at the time that the stroke is occurring. If they're not, then it makes you wonder, like, is there something that's driving their blood pressure down? Like, the normal response to having a stroke is to become hypertensive. And of course, when people are chronically hypertensive, they're certainly at risk for ischemic strokes and also hemorrhagic strokes. Also relating to blood pressure, somebody else had pointed out in the chat, or a couple of people, about PRES, posterior reversible encephalopathy syndrome, which is a condition of cerebral dysautoregulation, where our blood vessels are not able to constrict and dilate appropriately. And when people have risk factors such as being hypertensive, have kidney dysfunction, liver dysfunction, certain medications such as calcineurin inhibitors like tacrolimus in our transplant patients, or major electrolyte abnormalities, they could be at risk for posterior reversible encephalopathy syndrome, which is on the spectrum with hypertensive emergency. People can also call it radiographic hypertensive emergency. And it's also on the spectrum with RCVS, reversible cerebral vasoconstriction syndrome, which has similar risk factors to PRES that I had just mentioned, as well as drug use, especially our sympathomimetic drugs such as cocaine and ecstasy and LSD, and even marijuana can be a precipitant to RCVS, PRES, hypertensive emergency spectrum. You mentioned that in the HPI that she had several ED visits for recurrent headaches, and that does make me wonder if something's been brewing for her that could be on this PRES RCVS spectrum, as headache can be a prominent feature of that PRES hypertensive emergency RCVS spectrum. What RCVS, reversible cerebral vasoconstriction syndrome, also like the clinical features of that, in addition to having high blood pressure, that condition leading to seizures, can lead to ischemic stroke. You can think of when we have vasospasm, reversible cerebral vasoconstriction syndrome, the vessels can spasm down, causing ischemic strokes. When there's spasm, that can also cause severe thunderclap headaches. So somebody who gives a history of recurrent thunderclap quality headaches, they're feeling fine, and then all of a sudden, within 5 minutes, they have a headache that reaches maximal intensity. That makes you a little bit concerned about RCVS. The other thing about RCVS is that it can also cause hemorrhagic strokes, including high convexity subarachnoid hemorrhage. So not the subarachnoid hemorrhage that comes from like a berry aneurysm rupture, but the type of hemorrhage, a subarachnoid hemorrhage that can occur on the high convexities of the brain. And so those are other conditions that I'm thinking about. So we went over seizure, went over ischemic stroke, hemorrhagic stroke, PRES, hypertensive emergency, RCVS spectrum. She's also a little kind of low grade fever. Her temperature is 99.7. She's had recent headaches. She has what makes me concerned about her having a seizure. Could she have a CNS infection? Is another thought. I wonder with her drug use, how she used, you had mentioned cocaine, how she used her cocaine. Most people snort it, but I've heard that people can also, certainly people can also smoke it. But also, I've heard of people injecting cocaine as well. I don't know if there's other drugs that she uses that could predispose her to other conditions. One last comment I want to make about RCVS is also some other risk factors, kind of like a textbook presentation of RCVS would be somebody who's in a recent postpartum state. She's 49. It's possible she could have had a child recently. That's something else that I would like to know. Postpartum state, so within 6 weeks of having a baby, and also somebody who's pregnant in the 3rd trimester is also at higher risk of RCVS. And also people along with sympathomimetic medication use would be people who, so antidepressants, antipsychotics, and also nasal decongestants. So Sudafed, phenylephrine, that people can get over the counter can also put people at risk for that. So those are some of the conditions that I'm thinking of hearing this case so far.
Wow, amazing. Thank you, Dr. Shi. You gave us a very, very comprehensive list of differential diagnosis. So back to you, Dr. Zac.
All right, so I'm going to go through the past medical history and to allergies for the next aliquot. So Past medical history is hypertension, cocaine use, which was only intranasal cocaine use, and she has no reported use over the past 7 months. Other history are these headaches that have been attributed to her uncontrolled high blood pressure. And she has no prior surgeries or pregnancies. And her medications, which we were ultimately able to get a list from the facility she was in. She was on amlodipine and benzopril, esomeprazole, vitamin D3, and prednisone 20 milligrams a day. And we were unable to figure out why exactly she was on prednisone, and no one could tell us why. But that was a medication on her list. From a family history standpoint, no family history of seizures or other neurologic disorders. Her social history, she has this intranasal cocaine use and has been at the residential drug treatment program for the past 7 months. In the past, she had used IV heroin, but this was remote and over 5 to 6 years before this hospital stay. And she doesn't use any alcohol or tobacco products. And she has no drug allergies.
Wow, so Dr. Shi, from your list of differential diagnosis, this new piece of information does help you at all to narrow down some of the differential diagnosis, or what do you think about this?
It does. So I'm hearing that she has long-term hypertension that it seems like is not well controlled based on the information that we have, especially as people have attributed her headaches to hypertension. And so there are certain things that go higher on the list. So that includes, she's more at risk for stroke, ischemic stroke, and hemorrhagic stroke because of her chronic uncontrolled hypertension. Also at risk for that PRES, RCVS, hypertensive emergency spectrum. I am very curious about the prednisone 20 milligrams a day. Because that's an unusual dose for, for example, if she's been having recent headaches and goes to various EDs, it's very unusual to be prescribed prednisone for headaches. So I don't think that it's a recent prescription. It makes me wonder if she could have like an autoimmune rheumatologic condition that somebody diagnosed her with and put her on prednisone. Or if this is for some other issue, something else, but for example, like COPD, but you say that she doesn't use tobacco or asthma. You didn't mention that she has any pulmonary issues. So it seems I'm very curious about the prednisone, and so I would want to investigate that further, including asking them for the pill bottle. Let's see like who prescribed it. Let's call that person and ask them who prescribed it. Like we should do a little investigation, even if family or the facility or the patient cannot tell us about it. We can hopefully find ways to investigate like who thinks she needs prednisone and why. For example, could she have an autoimmune rheumatologic condition like lupus? People with lupus can have neuropsychiatric lupus, also called CNS lupus, which is like the new term, or it's not even that new, but it's the term that we're supposed to use as opposed to like lupus cerebritis, which is one, it's an old term, but only one manifestation of lupus affecting the central nervous system. But could there be some autoimmune rheumatologic issue that she may have, or some type of vasculitis, or a condition like that could predispose her to what seems like her coming in with a seizure, and she's still not back to baseline. And then it's very helpful that a family history was obtained. I always like to emphasize the importance of a family history, and I'm glad to know that there's no family history of seizures or neurological disorders.
Amazing. Thank you, Dr. Shi. So, yeah, back to you, Dr. Zac, so we can hear more about the case.
Yeah, so I'm going to take you guys through the basic labs and imaging and like initial hospital course with this aliquot. So a good bit of information, but I think it'll be helpful. So her CBC had a white count of 24 that was predominantly neutrophilic. Her hemoglobin was 12.8 with an MCV of 83. Her platelets were 480. For her basic metabolic panel, her sodium was 138, potassium was 3.8, chloride 102, bicarb was 22, and that's an anion gap of 14. Her BUN was 15, and creatinine was 1.1, which her baseline is 0.9 to 1.1. Her calcium, magnesium, and phosphorus were all normal. And then her total protein was 8.5 with an albumin of 4.1. Her AST was 96 and ALT was 26. And her T-bili and alk-phos were normal. She had a CPK of 725, a troponin and lactate that were normal. She also had a TSH, B12, HIV, and RPR tests that were all normal. And she had a UDS that was negative for cocaine or other substances, and a serum beta HCG that was negative, and had an ESR that was 119 and a CRP that was 11. And she had a non-con head CT that didn't show any acute intracranial abnormality. And so at this point, she was admitted to a hospital medicine service. Shortly after being on the floor, she had an episode where she had behavioral, or like sudden onset behavioral arrest with some lip smacking and right hand shaking that was concerning for a seizure. And she was given some IV Ativan and keproloded. And at that point was like pretty quickly hooked up to EEG, which over the course of the next time period showed multiple focal onset seizures arising from the left temporal region, some continuous left lateralized periodic discharges with superimposed fast activity, and then moderate generalized background slowing. And these all correlated with the clinical episodes that she was having. And these actually continued despite the initial anti-epileptic drug treatments, and she was started on additional anti-epileptic drugs and transferred to the neuro ICU, where she was intubated and started on a Versed and propofol drip for a status epilepticus.
Wow, that's a lot of new information. So, Dr. Shi, my question to you is, with the result from the EEG, how would you simplify this result for somebody who is not a neurology? It's just like an early learner. How would you make this result simpler for us to understand?
Yes, that's a great question. So with electroencephalograms, we can get so much great information, and everything that was shared about the EEG and about the clinical description of her seizure, it all makes a lot of sense. So with the electroencephalogram, the important things that I look at in the EEG report are, is that person having seizures or not having seizures? And if they are having seizures, are the seizures focal onset or are they generalized in onset? And that's the main breakdown between seizures, or when we classify seizures, or people can have focal onset seizures, and those focal seizures can come with somebody could have focal seizures with preserved awareness. So that would be something that we would know about clinically, not from the EEG report. But focal seizures with preserved awareness, or focal seizures with loss of awareness, or focal seizures that progress to bilateral tonic-clonic activity. In the case of a focal seizure that has focal onset, for example, in the left temporal lobe, like this patient, but then it generalizes, the abnormal electrical activity in the brain that starts in one part of the brain, then generalizes and crosses over to the other hemisphere. That's in contrast to somebody who has generalized onset seizures. So when they're having a seizure, all of the abnormal electrical activity comes on at once, all over the brain, all at the same time. And most people who have generalized onset seizures are people who are either having a toxic metabolic cause for seizures. So somebody who has alcohol withdrawal seizures, those seizures should be generalized in onset, or somebody who's having seizures from hyponatremia. Hyper and hypoglycemia related seizures are kind of the only toxic metabolic seizures that we allow to have focal onset. And so if somebody does come in with a glucose of 500 and they have a seizure, we also capture it on EEG, or clinically the description is a focal onset seizure. So like one side of their body starts shaking first, or maybe even one body part. First it's like the left pinky that starts to twitch, and then the left hand, and then it progresses to the left side of the body, and then maybe it generalizes to bilateral tonic-clonic activity. Anyways, that focal onset description in somebody who is hyperglycemia or hypoglycemia, we kind of like allow it, and we don't necessarily say that this person has high risk of having recurrent seizures because they're focal onset. But anyways, so the things that the other cause for generalized onset seizures would be people who have like childhood seizures that are generalized onset. For example, like absence seizures, or the juvenile myoclonic epilepsy, or benign Rolandic epilepsy, which I think has a new name now called like something with centrotemporal spikes. But most adults don't have generalized onset seizures unless they're provoked by a toxic metabolic cause. And most adults do have focal onset seizures. And what I want to know from an EEG report is if it's focal onset, where is the seizure focus? Because that is a part of the brain that we need to pay special attention to when we do imaging of the brain to see, is there a lesion that's causing that seizure? For example, a brain tumor, or leptomeningeal enhancement in that area, or a bleed, or an ischemic stroke, or gliosis, prior neurological injury, like a traumatic brain injury. Do they have a lesion that explains the cause of their seizure? And then the other thing I want to know from the EEG report is, do the seizures have clinical correlate? Where, for example, we, as the neurology team, or as somebody who's on the primary team, you might hear that, oh, this person had a seizure overnight and the patient really can't tell you anything about it. And so we might not have a lot of clinical information to go with, other than if that person were to be on EEG with video, they could visualize if that person did have clinical correlate with their seizure, that could then, make us aware of, is this person somebody who does have clinical correlate with all of their seizures, or all the seizures that are captured on EEG, or is this somebody who's having subclinical seizures, also called non-convulsive seizures, which is something we talked about at the beginning of this case. Of could this person, with their deficits in multiple cognitive domains, you were describing disorientation, and this person had like a mixed aphasia, they weren't able to speak properly, name, repeat, and couldn't follow complex commands. Was that person having subclinical seizures at the time? Is it something that we need to treat more aggressively? And so it's somebody that, hearing about this case, we didn't, I guess I didn't give too much input in the workup from initial presentation, which should have been, like, that person should have been connected to continuous EEG as soon as possible. Just with somebody who sounds like they had a recent seizure, they're not returning back to baseline, especially if it's been more than like 2-3 hours. If they're not returning back to baseline, that person just needs to be connected to continuous EEG. And one other comment, separate from EEG, is if that person, I asked for this patient to have a stroke alert activated, we assess them, we find that they're, aphasic with, even though with a tongue laceration, I would have wanted a CT angiogram as well with contrast to see if there could have been a large vessel occlusion causing this person's symptoms, and also with a CT perfusion study to see if there were to be an ischemic stroke with a large vessel occlusion, would it be something that would be amenable to thrombectomy, kind of maximally doing what we can neurologically to preserve the brain. Although, the most likely situation is that, probably this person does not have a large vessel occlusion. There wasn't any focality and, facial drooping or weakness in the arms or the legs. But sometimes people can have, for example, like a left M2 occlusion, left middle cerebral, the second segment of the middle cerebral artery could have an occlusion that could just cause aphasia. And people can have a seizure when they have an ischemic stroke. And so it's something that I, just covering our bases of what is the most urgent evaluation, could be most urgently intervened upon. I would have wanted to know how their vessels looked before having them admitted to the floor.
Great. Thank you so much, Dr. Shi. Back to you, Dr. Zac.
Yeah. Okay. So the next aliquot, I'm going to go through some CSF studies and some additional imaging that I think will be helpful. So the patient got a lumbar puncture, and the CSF showed a white blood cell count of 30 that was 88% lymphocytes. There were 8 red blood cells. The protein was 72, and the glucose was normal. The gram stain showed few neutrophils but no organisms, and the bacterial culture was ultimately negative. And there was a CSF infectious biofire sent that was negative. And it did show that there was other CSF studies where positive oligoclonal bands and an elevated IgG index. And then she did get a CTA head and neck, which showed multifocal irregularity and decreased caliber of the intracranial vasculature with severe narrowing of the left M1 segment, and then an enhancing focus within the left temporal lobe that was incompletely characterized on the exam.
Wow. So, Dr. Shi, so with this new information, what stood out to you?
What stands out? So there's so much that stands out. I'm so glad that she had a lumbar puncture. She was, low grade fever, had the leukocytosis peripherally, although that could be reactive to having a seizure. And the CSF is clearly abnormal. This patient has a pleocytosis, so that's an elevated white blood cell count of 30. It's not significantly elevated. Typically, when we think of somebody having bacterial meningitis, the white blood cell count, I mean, if you look at different texts, they probably will give you, there can be some variation in the numbers, but bacterial meningitis oftentimes has CSF pleocytosis greater than 500 or even greater than 1,000 white blood cells. Most of them would be neutrophilic. Somebody with viral meningitis may have white blood cell count that's greater than 100, typically lymphocytic predominant. Definitely that people can have viral meningitis with a lower, and even bacterial meningitis, but can have a viral meningitis with a lower pleocytosis like 30. And so that's definitely something that's still on the differential. I'm glad that they sent the biofire meningitis encephalitis panel, which tests for 14 pathogens via PCR. And that includes HSV and VZV, although the recommendation, even from the biofire laboratory, if you go to their website, is that if you have a high clinical suspicion for HSV, it can be ideal to still send the separate HSV PCR. And so that's something that I would recommend sending in this case. And the other things are that the protein is elevated. Certainly there's something inflammatory going on in the spinal fluid, in combination with the CT angiogram of the head and neck that is now obtained, showing multifocal irregularity and severe narrowing of that left M1 segment, and also an enhanced focus of the temporal lobe, of the left temporal lobe. There's, this person has vasculitis. We can, say that this person has vasculitis because of these vessel abnormalities and a CSF pleocytosis. And then also there's enhancement. So CT angiogram of the head and neck is done with contrast. And sometimes we can pick up other abnormalities, even though the CT angiogram is timed to look at the arteries of the head and neck. Sometimes we can pick up abnormalities in the parenchyma of breakdown of the blood-brain barrier. That's like why things enhance, is that there's breakdown of the blood-brain barrier. So sometimes we can pick up other clues for what's going on, or other pathology. So there's something enhancing in the left temporal lobe. And with this person having vasculitis, our differential is quite broad, including, could this person have infectious vasculitis? Could they have an inflammatory vasculitis? Kind of brings us back to the medications of like, why is this person on prednisone 20 milligrams a day? Could they have somebody, discover that they do have an autoimmune rheumatologic condition that they were kind of being maybe like inadequately treated for with just the prednisone? Maybe they were lost to follow-up. I mean, prednisone also, at 20 milligrams a day, depending on how long this person has been on it, if over a month, certainly, causes people to be immunosuppressed. We all know that when people are on more than, prednisone 20 milligrams a day or more for over a month, they should be on PJP prophylaxis, and they're also at risk for other opportunistic infections. And so goes back to us investigating a little bit more about that prednisone and also their past medical history. But autoimmune rheumatologic causes of vasculitis are on the differential. So like CNS lupus, like lupus vasculitis is one consideration. Also, somebody with like ANCA vasculitis, giant cell arteritis, she's just a little bit on the younger side for that. Typically, people are over age 50, but she's 49. It's something to consider, and that can affect the medium-sized vessels, which, all this like multifocal irregularity and the narrowing of the left M1 segment is like a middle-sized vessel. I would be curious to know on her CTA head neck if there was other signs of vasculitis extracranially. It seems like everything that we're told is all intracranial irregularity, but like, how does the aorta look? How do the great vessels look? And then, primary CNS vasculitis is also on the differential. And so that's a autoimmune inflammatory etiology that of vasculitis that's just isolated to the central nervous system, that we would see no signs of vasculitis outside of the brain. And a large infectious autoimmune rheumatologic workup would be performed, and there's no etiology seen. And primary CNS vasculitis would be then highest on the differential. And and that could cause enhancement, in the brain parenchyma as well. And we would treat that with immunosuppressive therapy. So typically like IV solumedrol, 1 gram per day for 3 days. And then oftentimes these people get like Cytoxan or rituximab. But I think we're on like the vasculitis pathway right now with this patient.
Amazing. So Dr. Zac, how many aliquot do you still have into the final diagnosis? You mute.
I can condense the next ones into 2. Does that sound good?
Is it okay, Dr. Shi?
Yes, of course.
Okay.
Okay. Okay, yeah, and just to answer a couple of your questions, there was no extracranial vessel abnormality on the CTA head and neck. And someone else's question mentioned cryptococcus. There was a negative CSF and serum cryptoantigen. So the next study that we got was an MRI brain with and without contrast and an MRA head and neck. So the MRI brain showed a left temporal lobe lesion with thick peripheral enhancement that was in close proximity to the arterial supply. There was also diffuse leptomeningeal enhancement along multiple lobes of the brain, dural thickening and enhancement along the anterior cranial fossa. And then there was multifocal luminal irregularities of the intracranial vasculature, but no abnormal vessel enhancement. So that's the MRI. And then I have kind of a host of other diagnostic tests that were performed. So in terms of an autoimmune workup, her ANA was positive. It was ANA bioimmunofluorescence at 1 to 160. But all of the other autoimmune serologies that we tested were negative. So her double-stranded DNA, Smith, SSA, SSB, rheumatoid factor, CCP, MPO, and PR3 ANCAs, antiphospholipid serologies, cryoglobulins. Her serum IgG4 was normal, and her paraneoplastic antibody panel from the serum and CSF was normal. Other testing, she had an SPEP and UPEP, which showed an IgG lambda monoclonal paraprotein that was likely consistent with MGUS per hematology. She had a CSF cytology and flow cytometry that were normal. And her CSF was also negative for AFB culture and fungal culture were both negative, and she had an MTB PCR that was negative. And I think I mentioned previously she had a meningitis encephalitis panel that was negative.
Did she have CSF VDRL sent as well?
That was negative as well.
So Dr. Shi, does this new information help you to make the diagnosis closer to vasculitis, or ruling out or ruling in?
Yes, I mean, I think that we can all agree that this person has vasculitis. There is vessel abnormality and the CSF is inflammatory. So this person definitely has vasculitis. The question is, what is the cause of this person's vasculitis that also has a concomitant enhancing lesion in that left temporal lobe? You were saying that there was thick peripheral enhancement of the left temporal lobe lesion, and then also diffuse leptomeningeal enhancement. And just one comment that the MR angiogram, I'm very glad that this person had an MR angiogram performed. Just for all of our learners, that typically we don't need to get redundant vessel imaging, but in the case where we're considering if somebody has vasculitis, sometimes there can be clues that can be obtained from an MR angiogram vessel wall protocol. And what you reported was definitely a vessel wall protocol MR angiogram. And so in a case like this, like if somebody has a CTA, it shows abnormalities of the arteries already, don't get a plain old MR angiogram of the head, get an MR angiogram of the head with and without contrast, and in the comments in capital letters, right, vessel wall protocol, please. Because it doesn't help to just get another MR angiogram. What you want is the vessel wall protocol so that you can see the vessels, if there's enhancement that's circumferential within the, like if there's enhancement at all within the arteries. But if there is it circumferential, or is it just you know, on one side of the vessel? Are there small vessels that also show abnormality, or is it just isolated to the medium-sized vessels that we already know about? Okay, so with this patient, you know, I would be very curious to know what our rheumatology colleagues think of this patient, because at the moment, with the positive ANA and then a large serum and CSF infectious panel, the infectious studies that have been sent and negative, it does make me wonder if she has an autoimmune rheumatologic cause for her vasculitis and brain lesion. And I wonder if there are systemic symptoms, either current or in the past, that would make them concerned about lupus or other autoimmune rheumatologic condition that could be clarifying. And so I would definitely involve our rheumatology colleagues for a patient like this.
Great, great. Thank you for the teaching. So, Dr. Zac, yep, go ahead.
Yeah, so we did have both rheumatology and infectious disease were very involved in this case. And she had no other systemic features that were concerning for an autoimmune, like a connective tissue or rheumatologic systemic syndrome. Yeah, and so her kind of ICU course, she had resolution of her seizure activity on EEG with all the anti-epileptics that she was on. Was ultimately able to be weaned down to just oral anti-epileptics, and was previously extubated and transferred to the floor, but had kind of continued issues with encephalopathy and confusion, and never quite returned to her baseline. And so we ultimately ended up pursuing a dural and brain biopsy, which showed parenchymal. So it was a dural and left temporal brain biopsy. It showed parenchymal and perivascular angiodestructive lymphocytic infiltrates, with lymphocytic infiltration of the vessel walls of small and medium-sized vessels with fibrinoid necrosis. And there was no viral cytopathic effect, and there was negative staining for mycobacterial and fungal organisms. And there was no clonal population of cells identified on flow cytometry. And that's the last aliquot. So I'll pause there and see if you want to give a final diagnosis, or I'm happy just to reveal it.
Yeah, Dr. Shi, what do you think? Do you have any possible diagnosis?
Were there granulomas commented in the pathology report?
There were no granulomas.
Okay. I'm wondering if this patient has, if the ultimate diagnosis is going to be primary CNS vasculitis.
Yes, yeah. So the final diagnosis was like a lymphocytic primary CNS vasculitis. And so she ended up getting 5 days of pulse dose steroids and cyclophosphamide. And she had a continued trend and improvement in her symptoms. So was discharged on a prednisone taper, PJP prophylaxis, and outpatient neuroimmunology follow-up with plans for repeat cyclophosphamide dosing in 6 months.
Wow, amazing, Dr. Shi. Spot on. Wow, to read the diagnosis.
Case.
Wow, this is great. So Dr. Shi, so for all the learners, when you hear about this diagnosis of primary CNS vasculitis, how is your management to this diagnosis?
So my management, the flow of this case, is very realistic for a patient that ultimately has a diagnosis of primary CNS vasculitis, which is a very rare diagnosis. I would say that I've seen it probably like 10 times total, and that's I guess 8 years, like 3 years of neurospecific residency, and then 5 years of working so far. So I think I've seen maybe like 10 cases total. So I would say it's on the rare side, and it is common for patients with primary CNS vasculitis to present either with with seizure or recurrent seizures, with ischemic strokes, much more common than hemorrhagic strokes. Also for people to have headache and constitutional symptoms like fever, low-grade fever, fatigue, and that it's a diagnosis that oftentimes, it is a diagnosis of exclusion. And so these are patients that we don't come to that conclusion, usually not even within like the first 3 days of admission, just because it takes time for us to get the MRI, do the lumbar puncture, wait for serum and CSF studies to result. I mean, honestly, there probably people are diagnosed. I haven't seen a study for this, but probably like more than 7 days after hospitalization. And some people might not even come to a diagnosis during their hospital stay, and they just get discharged. But um, the critical parts are excluding the infectious and other rheumatologic autoimmune causes for vasculitis, and then starting them on immunosuppressive therapy. And so these people are not going to get better unless they receive steroids, and then typically the cyclophosphamide, as we had mentioned. Um, and so it's no surprise that you were sharing the neuro ICU course and how this person didn't get better, and a brain biopsy was pursued, which is very reasonable. And many times our patients, especially if they have a good biopsy target, which this person had a lot of leptomeningeal abnormality, and also had that temporal lobe abnormality. I mean, the left temporal lobe is like not most ideal place to do a brain biopsy. So like right frontal lobe is the best place to do a brain biopsy. But certainly to make a diagnosis and to exclude other etiologies, it is important. And so it is something that we would absolutely advocate for. And with primary CNS vasculitis, I'm glad to hear that this person has not had ischemic strokes that we know of. We didn't hear of any of that on the MRI. And so in a way, it's fortunate that she might not have as much long-term disability as another patient who did have a larger burden of ischemic strokes before a diagnosis was made. I would be very curious to know how she's doing in follow-up, since for me as a neurohospitalist, I oftentimes only see our frequent flyers, and for people who are doing well, I don't get a chance to see them again.
Yeah, so wow, we are reaching to the end of the session. So before we end this session, Dr. Shi, would you like to share with us maybe 3 teaching points that you consider the most important ones that our learners should know?
Absolutely. So there's so many great teaching points in this case. I'm really glad that this was the case that was discussed. Teaching point number 1, as I had emphasized earlier, for a person that comes in with a neurological change with a last known normal within 24 hours and they're not back to baseline, it is very reasonable to activate a stroke alert, or at least have the neurology team or yourself do a thorough urgent kind of stroke, acute stroke assessment to see if there would be something intervenable. Now, we didn't go into this so much, but now our TPA window has been expanded, where we give TPA for wake up stroke. So you don't know the last known normal, or like maybe the last known normal is like the night prior, and then they woke up this morning, or somebody finds them this morning, and nobody can say if they were normal any time prior to last night. We do have a protocol, whether with MRI or CT perfusion imaging, to offer that person TPA, and we certainly can do thrombectomy at up to 24 hours, and sometimes even beyond that. And so we have acute interventions, and I would hate to have a patient miss the opportunity for an acute intervention if a stroke alert were not activated. So this is a patient that I would have wanted a stroke alert activated, and I would have wanted a CT angiogram earlier than later. The second teaching point is that with somebody who comes in with a first-time seizure, we didn't go over this so much, and I'm glad we have a chance to talk about it right now. Our decision tree for when to start somebody on an anti-epileptic depends on their risk for recurrent seizure. So we know of this person being found down, she had blood in her mouth, everybody's suspicious that she had a seizure. And so that's, and even though she's not back to baseline, that is not necessarily a patient that is not a patient that needs to be loaded with an anti-seizure medication right away in the ED. But what would have been important is to connect her to continuous EEG as soon as possible when we realized that she wasn't returning back to baseline after a few hours. And we might have captured her having subclinical seizures, or at least we would be able to capture if she does have a recurrent seizure or if there's any abnormality on the EEG. For example, if she were to be connected to EEG as soon as, like 2 hours after she hit the ED and she wasn't getting back to normal, um, we saw that there were left-sided lateralized periodic discharges or some other epileptiform discharges, that person should be started on an AED at that moment. We don't need to wait for her to have another seizure. Also, if her imaging had demonstrated any abnormality that would predispose them to seizure. For example, the non-contrasted head CT had looked normal, but if the CT angiogram had been done and we saw that left temporal lobe enhancement, we'd be like, okay, this person has a risk of having a recurrent seizure. And we could have started them on an AED at that point and not had her like go into status epilepticus and had to transfer to the ICU and intubate and put on drips. And so earlier intervention could have been done. I mean, this is all easy to say, like, in discussion later on, and at the time of assessing a patient, there might not be as much clarity. But I would hope that our learners recognize that we can intervene sooner. We don't have to wait for somebody to have a second seizure before starting them on an AED. And then the third learning point is that primary CNS vasculitis is rare, but it's a great condition to know about. What's much more common are infectious and inflammatory causes of vasculitis. And so it's important to evaluate for those causes because much more likely to see somebody with VZV vasculitis or vasculitis from neurosyphilis than somebody with primary CNS vasculitis. One last comment is that I've said RCVS a ton, so that's I just want to under teaching points we should change it to reversible cerebral vasoconstriction syndrome, not cerebral vasoconstriction syndrome, RCVS.
Oh my God, thank you so much, Dr. Shi. Oh my God, this is amazing teaching point. Thank you so much, both of you, for this amazing case. And thank you so much, Dr. Zac, for presenting this case. We learned a lot. Thank you, the scriber, Doc Parisa, and teaching point we have Kuchal. And thank you everybody for joining this session. I hope to see you guys in another episode. Bye.